Hello, folks. Dr. Paul here for a unit summary for Unit 9. Wow, things have really flown this semester. Hopefully, you've enjoyed the course thus far. This unit, we talked about individual versus relational perspectives. And I think I need to talk a little bit about that because judging from many of your answers on the relational portion of the assignment, it seems like there's been some confusion. Let me talk a little bit about individual pathology. So, the medical model, which is pretty much a person or people consult experts with some problems that they're having, and the expert does some kind of diagnosis and assessment, and then prescribes some sort of fix or change, or in the case of medicine, provides some medicine or some kind of rehabilitation. And the medical model is very much firmly established even in the mental health world. The original brilliance of family therapy was a direct challenge to the medical model. And basically, um, what was traditionally individual diagnosis or individual problems were seen from a more relational perspective. So it didn't matter whether it was schizophrenia, anorexia, a couple with problems, tantrums, bipolar, anxiety, any disorder that you can name. Um, Early family therapists, when they started to look at people in context, realized that the behavior that were so called individual pathology, when you look at the behavior in context, you can also explain that behavior as part of an interactional cycle. So, family therapy being founded on systems theory, you hear the term systemic perspective, or as it's said in this unit, a relational perspective. Sometimes you hear interactional as another way of saying the same thing, or sometimes just family perspective. These are all pretty much synonyms for the same idea that we're, on the one hand, looking at individual pathology perspectives. This would be psychodynamic, cognitive behavioral, humanistic, even has some individual pathology, versus the systemically informed models, structural, strategic, MRI, solution focused, narrative. These are all approaches that were can trace their roots back to systems ideas and how, again, if you look at people in isolation, you'll see individual pathology. If you look at them in context, that so-called symptom is just one piece of the interaction. So even in a situation where a young woman is diagnosed with anorexia, if you look at that behavior in context, you'll see a pattern, and I'll make one up now. Mom tries to get kid to eat, kid refuses, mom escalates, dad comes in and berates mom for being too hard on the kid, possibly, and kid gets permission covertly from dad not to eat. And so the more mom tries to get kid to eat, the more kid doesn't eat. The more dad gets activated to yell at mom, and then mom backs off, and the kid doesn't eat, and the cycle goes on and on and on. And we just punctuate anorexia and locate that pathology in the individual. And the early family therapist said, if you look at the behavior in context, there is no one um, place that the pathology really resides. So we call it the identified patient or the identified client, which is a realization that this is the person that the family has identified as the problem. But with a systemic or relational lens, we realize that the sequence of events are such that the symptomatic member is just one person in a cycle. So in this unit, we had you look at a case from an individual pathology perspective, where that's actually the part that you all did wonderful on, because individual pathology is so much a part of our culture. And even within the world of family therapy, there are many individual pathologists because they haven't really embraced the shift to a more systemic way of looking at things. And you don't just decide to think relationally or systemically, it's something that takes some practice. Again, because the individual pathology model is so steeped in our culture that a person is an alcoholic, a person is depressed, a person is fill in the blanks, an adulterer. Whatever it happens to be, we are a culture to thinking about it in terms of an individual pathology. And I think, as I said in a previous summary, there's no behavior that you can't look at in context. And so, uh, diagnostic labels, DSM labels, or any kind of pathologizing labels really fall away when we can see how a behavior or a belief makes sense in context. So, the idea of this assignment was for you to have practice going back and forth between the two worlds of individual pathology, which is quite easy, especially when we're talking about addictions. Again, it's very much a cultural idea that it's the addict with the problem. Well, from a systemic perspective, again, the addict is just one arc of the circle. And if you charted using behavior, you would see a whole cycle of interactions around using, um, typically involving attempted solutions to get the using to stop that tend to not only perpetuate it, but actually exacerbate it. So I think there's been some misunderstanding in this unit on what relational means. And so maybe we could have been a little bit clearer around we want you to view it from a systemic perspective. And in some ways, the question was a little tricky because it said, from a systemic perspective, who is the client? And really, the relationship system is the client. There's no one individual from a systemic perspective because you're looking at the entire system and you're seeing how symptoms make sense. If we look at structural family therapy, it was the same thing, only the symptomatic member was same thing, the identified patient, but the dysfunctional hierarchy, which is the according to the structural model, it was the dysfunctional hierarchy that produced the member that's symptomatic. And if you correct the hierarchy and parents are in the parental subsystem and kids are in the child subsystem, then symptoms will disappear. Same idea, but just a little different language. Doesn't matter whether we're talking about experiential, Bowenian family therapy, again, MRI, big shift from viewing things individually and systemically. And again, it does take some practice. Our minds and our brains tend to go to individual pathology land. So I think it's important to be mindful that even though we're in a field called family therapy that has been built on systems theory, um, there's a great deal of contradiction in our field because there are still a lot of individually minded therapists that see family therapy more as just a different modality rather than a completely different way of understanding problem formation and problem resolution. So, okay, individual versus relational perspective. So again, I think in the relational formulation, you want to begin to look at any symptomatic individual in context and say, okay, well, what is the pattern of interaction around that symptom? The more this person does this, the more this person does this, the more this person does this, the more this person does this. If let's just take an example of a couple and the stereotypical my wife nags and nags and nags, and our main problem in our marriage is all my wife does is nag at me all the time. Nothing I do is good enough. And you interview the husband, and you're very much pulled to what's wrong with this woman. He's got a whole laundry list of reasons why there's something wrong with his wife because she nags him about X, Y, Z, A, B, and C. Well, then you interview the wife, and you learn that the problem in their marriage has nothing to do with nagging, but the fact that her husband is not available to her. And so, from her perspective, he is running away from being closer to her. He is running away from expressing feelings and emotions with her, and he's the problem. Clearly, he is in denial about how he's bottled up emotionally, and he's very unavailable to her. And so you have two completely different realities. So it's a good example of how you can buy into the pathology of one over the other, Or you can look at it as the more she nags, the more he retreats and becomes less available. And the more he becomes less available, the more she nags. And that complementary dynamic is the same dynamic around every therapeutic problem. The more X is done, the more Y is done. The more A is done, the more B is done. And so behaviors are two sides of the same coin. So we want to be careful, though, that we don't move from pathologizing individuals to then just pathologizing relationships. And I think that was a brilliant move on the early family therapists, but really they just moved the locus of pathology from the individual to the family. And now we talk about family dysfunction, at least before postmodern ideas that began to question whether anything has to be dysfunctional or not. And that's where we have narrative and solution and strength-based therapies. So, okay, hopefully that distinction is cleared up a bit. We also talked about addictions and infidelity in this unit. And again, these are two areas. Let's look at addictions first. There are so many cultural ideas that are embedded within our cultural psyche about addictions. I'm sure that there are many of you that believe that an addiction is a disease. The disease model is very much steeped in our culture. Um, for many, that is fact. Um, for many of us, that is one possible discourse. It's a dominant discourse about addictions, but it's certainly not the only discourse. Um, so when you encounter a case where there's an addiction, you really have to look at your own ideas about it because they have been shaped by the same culture. And there are many therapists that believe, well, if you have an addiction, the first thing you have to do is fix that addiction and go off to AA. And that's the only way to get help, or NA, or some kind of anonymous group. Again, that's one discourse on how to look at addictions. There are many therapists that have no trouble seeing clients in therapy who also have addictions because they don't see it as separate problems. Again, can you look at an addiction in terms of an interactional cycle? And when you begin to look at the context, the wider context, you say that this behavior doesn't happen in a vacuum. Um, and even a person that lives alone, there's an interactional context around using that supports their using. So it's a good idea to examine some of your own biases and assumptions. Infidelity is another good example where we become individual pathologists around things like addictions and infidelity because the person who's having an affair is obviously the problem. Um, when I work with couples, and oftentimes an affair is part of the picture, um, it's very helpful to gently, when there's an opening, to begin to look at or ask the question, was this infidelity, is that the problem or is that the symptom? And right away, that gets people thinking about the context that this affair happened in. And not every situation or case is the same, but by and large, it'll resonate with many couples that infidelity doesn't typically happen in a vacuum. And so we want to walk that fine line between staying connected to the person who was hurt by the infidelity and not giving permission for the infidelity, at the same time staying connected to the person who has committed the infidelity by putting it in context and putting it in perspective. As you can imagine, this is a very fine line to walk. I think a mistake that many therapists make is not examining their own assumptions around infidelity, and thus they tend to side with either the perpetrator or the victim. Either the perpetrator should be forgiven and there was a whole reason for it, and many perpetrators of infidelity have lots of reasons that make good sense, or they side on the other side with the quote unquote victim and feel like they're the one who suffered because the other one has committed the adultery. And really, you want to look at some different framings that can consider both rather than either or perspectives. The other thing about infidelity that is very interesting is that people define infidelity in very different ways. And I feel pretty confident saying that it's different for every couple. I've worked with couples where the worst thing you could do would be intimacy with somebody. And then how they define physical intimacy, those lines are drawn in some very different places for people. Some people would consider one thing, one kind of physical connection or physical incident, infidelity, and another couple may not. There are other couples that I've heard people say, I could care less if she was with another man, but as long as it's just physical, it's okay. And I've heard both men and women say that. Um, so I think it's important to be open to a diversity of interpretations around what is or is not infidelity. Certainly worked with a number of couples that have open relationships and wouldn't even consider um, sexual or emotional relationships outside of their marriage as infidelity. So these areas and issues really cause us to question, and it challenges us to not impose our beliefs um, inadvertently. I think the same thing could be said about definitions of addictions. Um, we draw lines in very different places when it comes to addictions. Some people um, using X amount um, would be considered an addiction, and for other people, a completely different amount would be considered an addiction. And yes, there are guidelines about um, if you fit certain criteria, then this means that you have a problem with addiction. But I found that in practice, people tend to draw their lines in very different places. So you have to decide for yourself as a helper, and there's really not a right or wrong answer, but you have to decide for yourself, where do I fall when it comes to drawing these lines? Do you see it as your place to educate people about what the popular literature says what an addict is and what an addict is not? Do you see your role as more being open to a diversity of, of definitions of addiction and explorations of how addictions should be tackled in terms of people getting help? And is it even okay for you as a therapist that people aren't ready to tackle their addictions? And you don't necessarily have to see them in denial or being resistant because they're not ready to give up their addiction. So, welcome to a very strange place that you get to as a helper because you begin to question some aspects of your belief system and reality that tend to turn your world upside down. I think again with addiction, like infidelity, you can begin to question whether an addiction is the problem or is it a symptom. Beginning to do that for yourself offers many more possibilities and opportunities for helping people to get unstuck from their definitions of things. So I would encourage you to think about cause and effect and thinking about turning it upside down. Generally, in therapy, consensus can be a dangerous thing. It closes off possibilities. The more question, the more light we shed on things that open up more questions, the more room there is for people to explore who they are and who they are ultimately becoming. So, okay, hopefully this has been helpful. As before, it would be great if after you view this, you would just post a comment or two about something that stuck out in your head, or something that you want to share that we sparked you to give some additional thinking to, etc. Okay, great. Thanks.